much. I hope everybody can hear me. Again, I can see that we have a lot of participants. The numbers just going up all the time. So it's very exciting for me to be here on screen. I wish I could be there to see you all, but again, this is probably a more easy way of giving talks like this. I'm very happy to have been invited. It was great. I met Sandipan in Paris at the SPIN meeting where we had a talk, and then later on I got this invitation. And also to talk about the impact of new treatments on comorbidities in atopic dermatitis. As Sandipan told you, it has been my area of research for quite a while, actually since I was a medical student, to work with atopic dermatitis. I've worked here for many, many years, and I did the first part of my research work in Tokyo in Japan, and later on also in collaborations with other parts of the world. Now, before I start talking, let's just see if I can go one forward here. These are my conflicts of interest. I'm sure that not so many are very interested in these. So let me move on to this. This was the hospital where I used to work. It was built in 1911. It's an epidemic hospital, which was on the outskirts of the city where I live, which is Aarhus, which is the second largest city in Denmark. Copenhagen, our capital, is the biggest one. But since I have visited India before, I know that the size of our cities is probably not impressing you very much, since that in the entire country, we're about 5.8 million people, which does not even, it's about the half of some of your very big cities. But still, this was built back then. This is where we worked until very recently, where we moved out to a new hospital that contains all of the specialties. This is the hospital as it looks today. It is the largest hospital in Scandinavia. I'm not sure if you can see my pointer, but the Department of Dermatology is in this part of the hospital over here, and our inpatient clinic is up here. So you can see we're only a very small part of a very large hospital. Still, we have a long tradition for dermatology and also for research in dermatology. These are the departments that you will find in Denmark. We have 5 main departments over here in Copenhagen. We have 2 large and 1 smaller department. We have one in the middle of the country, and then we have my department, which is here in this part of Denmark, connected to the small department here. And also we have a small university clinic up here. So all in all, this is what you see. We're only about 120, 130 dermatologists in this country, so it's not a huge specialty. But enough about that. I just wanted to give you some background on from where I'm talking. I'm very aware of the fact that some of the things that I might be saying may not be valid in India because we work in very different environments, in very different settings. But I think this is something that might be a subject for discussion afterwards. So let's just get on with the subject on this interesting talk. Now, you all know atopic dermatitis, and I love to show this picture of a small boy who came in our clinic some years ago, I think 10 or 15 years ago. It is a picture that was given to me by my old mentor, Professor Peterson, who unfortunately passed away some years ago. But as you can see here, this young boy has gone to the photographer. He has eczema all over his body. His clothes has come off. He has been given a dummy that he puts into his mouth. He has these 2 biscuits in the other hand, and he starts scratching himself. So this is really what we see, right? These are also part of the major criterions for atopic dermatitis: the pruritus, then the morphology and the distribution of the eczema, the fact that it's a chronic disease in these patients, and also that they have a family history of atopic dermatitis. These are the major criterions. You need 3 out of 4 if you go by the Hannafin and Riker criterions, and then 3 or more of about 23 different criteria. I've put up the most important ones down here with the dry skin, the ictericis, the elevated serum IgE, nipple eczema, keratoconus, and there are plenty more that I will not go into. And again, I would have to say also that there are many different definitions of atopic dermatitis. This is the one that we usually use for two reasons. One, it's very easy to remember, and two, Reitzka was the professor in Oslo, not so far from here. So in many ways, it's based very much on the Scandinavian population. John Hannafin is in Oregon, and he has also been part of this. But still, this is what we use for the definition of atopic dermatitis. Now, you all know that there are comorbidities to AD. We know that we have all of the atopic diseases like asthma, hay fever, and food allergy. I'll go a little bit into that in a moment. We have cardiovascular diseases. We had a lot of research into that because we knew that among psoriasis patients, this was really a risk. We don't know quite yet if it's also a risk in atopic dermatitis. Psychiatric diseases is certainly something that we have an increased risk for in atopic dermatitis. It has an impact on the patient's social and educational life, on infection, and also an increased risk of contact dermatitis. I'll try to go into some of these before we talk about the treatment. Now, we all know, or you probably also know, that this disease is the type 2 inflammatory disease. This is a common inflammation that's underlying the pathophysiology in a lot of different diseases like asthma, like eosinophilic esophagitis, like rhinoconjunctivitis, and it's mainly driven by IL-4 and IL-13, which are also the targets for a lot of the treatments, the new treatments that we see today, and which I will tell you a little bit about later on. So this is really the main part, and you can see here we have all of these receptors, and I'll try to give you an insight into what this means for atopic dermatitis patients. You can see here, these are the typical type 2 diseases, and this is actually handled by different specialities. We have atopic dermatitis, which we take care of in dermatology. We work very much together with the allergologists and also the pediatricians, which take care of this in Denmark. With the food allergy, eosinophilic esophagitis is together with the gastroenterologist. We have the ear, nose, throats guys for the chronic rhinosinusitis, and also we have the pulmonologist for the asthma and the eosinophilic chronic obstructive pulmonary diseases. But the main culprits in this, and those that we target, are these cytokines and these cells. IL-4, IL-13 axis is very, very important in type 2 inflammation. There are a lot of other cytokines, I would have to say that already. And then we have these main players of the cell. We have the Th2 lymphocytes, we have the B cells, we have the innate lymphocytic cells of the type 2 kind, we have Langerhans cells and eosinophils. These are the major players when we talk about type 2 inflammation. And this would lead us on to talk about the atopic march, because it's something that we've been talking on for a very long time. You know, do the patients who have atopic dermatitis when they're born, they have this type 2 disease, do they develop the other diseases later on, like asthma, like rhinitis? And there's a very nice study here from 2014 where you can see that when you put in the age, you can see that there's an increased risk of eczema around the age of 1 or 2, along with food allergies. Rhinitis is a lot later on, as is asthma. And the thing here is that it is probably not the same disease. You might have an increased risk, but what you see here is that a specific age point, they will have this kind of type 2 inflammatory disease. The question, of course, would be, can we, for example, by treating early on, treating atopic dermatitis or treating food allergies, stop the development of rhinitis or asthma later on in life? And this is really something that has been discussed for a very long time. I have to say, I'm a bit pessimistic on whether or not this is doable. We might be able to inhibit food allergies, for example, or allergies altogether, because they might get sensitized to the skin. But I do not think that this is a sequential way that the disease works. And there's a study here where you can see you have very different patterns of this disease. And you can see about 3.1%, you can see this so-called atopic march, where you will have the development of the rhinitis after you have the eczema, and you will also have the wheeze coming on from the age of 1 year. But there are other types that are much, much more common. You can see eczema only in 15%, and you have persistent wheeze with later onset rhinitis. So all of these combinations is very different. And what I think you really see is that different ages have different diseases, but that is not something that should stop us, of course, from treating the patients. So in many ways, I think this is a very important slide in order to discuss this kind of disease and how it develops. I'm just going to find the right place to touch it. Now, if we move then to some of the psychiatric diseases, what we do know by now is that atopic dermatitis patients have an increased risk of depression. They have an increased risk of suicidal ideation, suicide attempts, and also actual suicide. Suicidal ideation is the thoughts about killing yourself, ending your own life, thinking life is not worth living, whereas suicide attempts almost gives itself, but it's actually also to really have the thought of committing suicide, going to the kitchen drawer and taking out a knife and putting it back without hurting yourself. That's actually also a suicide attempt, because you have the intent to take your own life, even though you will regret it, but it increases the risk of actually doing something about it later on. They also have an increased risk of attention deficit and hyperactivity disorder, sleepless nights. Of course, that also includes the parents. Everybody who's had a child with AD knows that it can lead to very long nights with no sleep. There's an increased risk of anxiety and also an increased risk of using anxiolytic antidepressant. And I think that in many ways it has been underestimated how much this really affects people with atopic dermatitis. So let's go a little bit into that now. You know that sleep disorders do give a poor quality of sleep. It increases the latency, that means the time until you fall asleep, probably due to itch, probably due to pain in the skin. It gives you an increased sleep fragmentation, that means you wake up a lot more, you have very small periods of time where you sleep, and you have thereby also a poor efficacy of the sleep. That means that it doesn't give you the rest and the time for the brain to recuperate for the next day. And you also will have a lot of difficulties in waking up. And all this in turn, we do know, increases the risk, that is the quality of sleep. For ADHD, it actually also increases the risk of obesity, and it increases the risk of hypertension. So maybe this is also one of the explanations that we sometimes see an increased risk of hypertension and early death by myocardial infarction. So this is really where we have the AD and the sleep disorder and how this works together to give all of these diseases. And we know here, this is the thing that I talked about, suicidal ideation, suicide attempts, and also suicide, which in the US is the 10th leading cause of death. I am not sure about the numbers in Denmark. I'm not sure it's the 10th, but it's up there. So it's really something that we need to take very seriously. And there are several different studies. Many of them are not very big because it's very difficult to do big studies on this. But this is a study from England with a study of 146 mild to moderate eczema patients where 2% had suicidal ideations and 2.7% wished they were dead. There's a Danish study here, which is very much markedly increased, where AD patients had almost 20%, 1/5 of these patients studied had thoughts about suicide versus 6.8% in the healthy population. We have a German study with almost the same numbers. And finally, we have a British study here, which I also think is very interesting, that not only among the patients, but also the parents, there was an increased risk of having thoughts about suicide. So something to be taken into account. Here, I tried to put together some sort of a algorithm or a scheme to illustrate what really happens if you have atopic dermatitis. You get an altered self-image. You don't think of yourself as normal. You think of yourself as being different. And this can, of course, lead to depression by itself. But it can also lead to social isolation, which in turn also leads to depression, anxiety, and ADHD. You have the itch from the disease. We talked about that in the beginning. Itch leads to social isolation. Some people think it's disgusting if they itch. They might think that other people think that they're contagious. And again, loss of social contact, but also sleeplessness. And all of this can lead to a loss of career opportunities. And again, this may lead to depression, anxiety, and ADHD. We could talk a very long time about the inflammation by itself, because inflammation in itself actually also causes changes in the brain and how it works. We know that if we treat patients with interferon alpha for hepatitis, they are very prone to get depression. So having a high level of different kinds of inflammatory cytokines may lead to altered psychological functioning and to psychiatric diseases. Now, if we just turn a little bit to inflammation and to the cardiac disease, you know, this made the front page of Time magazine because this was the secret killer. And for a very long time, there's a lot of studies going on in psoriasis, where we know that they have this increased risk of having myocardial infarctions. They get blood clots and so on and so forth. And we had a PhD student here in our department who wanted to do studies to see if by treating psoriasis, and I am really saying psoriasis, if they could treat psoriasis and sort of either stop or reverse the changes in the vessels around the heart with biological treatment. And he came to me to say, well, I need something, or some patients who do have inflammation, and I need them as a positive, negative control in the sense that they should not have changes in their coronary vessels. So I found a lot of AD patients for him, but what we found was that there was actually also an increased prevalence of coronary artery disease in AD patients. So this turned out to not really show what we wanted it to show. The way we studied it was using this coronary CT scan, where it was not my method, it was his. He looked at the coronary arteries. He sort of split them into segments and looked at how many had plaques in these 18 segments of the coronary vessels. And what was really interesting was this, where you can see that the distribution of these vessels and the luminal abnormalities, you could see here that when we looked at stenosis, actually mild and moderate were even more prevalent among the atopic dermatitis patients compared to the psoriasis, whereas the severe ones, where they really closed off, was limited to the psoriasis patients, and it was even more than compared to controls. So what we thought was that probably, maybe, there is something. The number of patients here, I think, was about 50, so we needed to do some more studies. And we did this study on the registries that we have in Denmark, because we have since the 1970s been registering all diagnoses made in the hospitals, and we are able to go back into these registries and look at what happens to these patients. And what you can see here is that if you have AD from a very early age, compared to the general populations, you have an increased risk of myocardial infarction. So this was really a study that we did here. But I have to tell you also that we have another group, one in Copenhagen, that we work very closely together with, and they did the same study, but used some proxies and an algorithm to sort of guess whether the patients were smoking or not, because we have not registered that in our registries. And if you use this algorithm, maybe the increased risk of having myocardial infarction disappears. So that is to say that maybe it was because these patients are smoking. Maybe they smoke more, but still, that's still something to tell us to help our patients to stop smoking, because then we will be able to stop maybe a lot of these myocardial infarctions. But on the other hand, in the US, Jonathan Silverberg showed that there was also an increased risk of myocardial diseases in atopic dermatitis. But maybe over there it was because the patients had a more sedentary lifestyle, with also smoking and not eating very healthy. Lastly, about the comorbidities, if you can call this a comorbidity, I would just like to show you that in Denmark, these are only studies that are performed in Denmark, but they're probably also true in other countries, that they have an increased risk of not getting educational level, the same educational level as their peers. So if you have AD, your educational level will not be as high as as it potentially could be if you were well treated or if you did not have the disease. We can also see that there is an increased societal cost for having patients with atopic dermatitis. This was a study that I did together with Professor Tyson from Copenhagen, where we looked at the expenditures in both the health system, and we also calculated the expenditures from not being at work, and we could see that there was an increased cost of being atopic dermatitis patients. Now, what I really wanted to show you here, this is a map back from my time in Tokyo when I lived there, when I did my PhD. And sometimes when you look at a map of the subway of Tokyo, you feel like you're looking on a map of the immunological things that takes place in the skin. And I've tried to illustrate it here. This is from a paper here from Chao Yu. And you can see that there's a lot of new drugs on the market, whether we're talking about the chronic phase, the acute phase, or the non-lesional phase. These are some of the antibodies. And if you look here, what you can see is that we have monoclonal antibodies now. Especially we have the IL-4, IL-13 antibodies. There's also OX40 antibodies, TSLP antibodies, the itch antibodies, IL-31. All of these are coming to the market. I will not spend too much time here because I'm going to show you a little bit about the results, because this is what we can really do to treat the patients, besides from the old drugs, which we will not spend too much time on since we were going to talk about the new treatments. We also have small molecules. We have the JAK inhibitors, we have PDE4 inhibitors, we have histamine 4 receptor inhibitors, and all of these are, some of them are on the market already, some of them we are using here, some of them are still in clinical trials. So let's try to dive into some of these new treatments and some of the results that we have seen on this exciting new time in atopic dermatitis. Before we go on, let's just have a look at how it works. These are JAK inhibitors, but you can see here also we have some of the most used antibodies now. Dupilumab, I guess everybody knows, is the anti-IL-4, IL-13 receptor alpha antibody. It inhibits the effect of IL-4, but also IL-13. Then we have lebrikizumab, which is not yet on the market. We have tralokinumab, which is on the market and which inhibits IL-13, and it's binding to the receptor. Then we have nemolizumab, which binds the IL-31, which is especially known for its impact on the itch, but also on the inflammation. All of these receptors are like the typical cytokine receptors. That is, when they join, they will activate kinases, which will then lead to intercellular signaling through the STAT pathway by phosphorylating STAT molecules, which will then act as transcription factors in the nucleus of the cells. And you can see that these are the new drugs that we have on the market now, especially for AD. We have baricitinib, which inhibit JAK1 and JAK3, and you can see this is important for IL-4 signaling, also for IL-13 signaling, actually also for IL-31 signaling. And we also have the so-called specific inhibitors abrocitinib and upadacitinib, which inhibits JAK1. And again, you can see IL-4, IL-13, IL-31 is selectively inhibited or stopped by these JAK inhibitors. So all in all, these are the new treatments, and these are the ones that we are going to talk about and which is already being used for the treatment of atopic dermatitis. Now, if you look, these are some of the first studies on dupilumab, Solo 1 and Solo 2, and these were, everybody was very excited about the results, and understandably so. If you look at these two studies, which are similar, where they gave dupilumab every other week or every week in 300 milligrams and compared them with placebo, you can see that there was a huge number of patients who had reduction in the EASI. This is the average EASI reduction, and this is a numerical rating scale for itch, and you can see there was a significant effect of using dupilumab, even if it was only every other week, which is now standard dosing of this treatment. Tralokinumab from the EXTRA1 and EXTRA2 studies also showed a very nice and significant effect, perhaps not at the same level as dupilumab when you look at IgA, but also at the percentage of patients achieving 75% reduction of EASI, the EASI 75, but still this was actually also very nice results, and perhaps if they had run for longer than 16 weeks, we might have been able to see a better effect, but it's still something that I need to see what happens in real life. We also have nemolizumab, and again, look at the itch. This is VAS score by day 16, and what's really impressive about this drug is the intent of the speed with which we see onset of this disease. EASI score, perhaps, maybe not so impressive, but still, I think it does really show effects which are similar to tralokinumab, so probably it also has anti-inflammatory effect to use the nemolizumab. We have one of the small JAK1 inhibitors, baricitinib. This is JAK1, JAK2 inhibitor, and you can see here there is a significant number of people who achieve EASI 75, also EASI 90. These are two similar studies, and if you add topical steroids, it's an even better effect of these drugs. Compared to aprocitinib, we have here J8 mono 1, J8 mono 2, two similar studies using 100 milligrams or 200 milligrams of aprocitinib, compared to this one, which is J8 compare, in which we also add topical steroids to the treatment. And you can see here very, very impressive results. 63% achieves EASI 75 if you use the high dosage of aprocitinib compared to 12% of placebo. We see the same thing in the similar studies, and when adding topical treatment, it even gets better, which is also to be expected. Upadacitinib shows similar results of aprocitinib. It's also a JAK1 inhibitor. You can see here 80% in the high dosage actually achieves EASI 75. And these are the two studies in which you just compare the dosage. If you have 80 up, you add on also TCS. And here you run it comparative to dupilumab, and it really seems to that upadacitinib might be superior to that treatment. What we also could discuss later on is the safety profile of these, but so far it seems that upadacitinib is also safe. I know there's a black box warning on all of the JAK inhibitors right now, but we are already using these drugs. They have been approved by both the EMA and the FDA. Finally, we also get some new topicals. We have topical JAK inhibitors also. The delgocitinib is a topical JAK1 inhibitor, which actually turns out to have a very nice effect on mild to moderate atopic dermatitis. But again, these patients who were involved here did not have a very high EASI score. So whether an EASI 50 or an EASI 75, what does that mean? It's very difficult to say. Crisaborole, not approved in Europe, at least not in Denmark. It's approved in the US as PDE4 inhibitor. Maybe it has a good effect. It's probably a little bit not as good as potent topical steroids, but on the other hand, it might be steroid sparing. So I think it's still something that might be used. There's some upcomings. One I think is very, very interesting is tapinarof, which is an aryl hydrogen receptor modulator, and you can see a very, very high efficacy of this drug if you use it twice daily in a 1% solution compared to just the vehicle. It really does seem to have a very good effect. Finally, you have ruxolitinib in also a topical. There's very, very few studies in this. I just wanted to show you some of them, that this also seems to be a very promising drug coming up right now. And then finally, we are also getting some results on using microbiome changing therapy. This is a study from the JAMA. I think it's very interesting, but again, you have to remember that it is very, very few patients that used it, where they took patients with mild to moderate atopic dermatitis, isolated coagulase negative staphylococcus from the patients, upformed these, and put them back into a lotion, and then added them on to the patient's skin. And what you can see on the very right-hand side was that it actually did have a positive effect on the patient's eczema. I think there's a lot of promise in this new approach on manipulating the microbiome, but I still think that we are very, very far from the target, that we still need to find out how do we manipulate it and what to manipulate. So are we there yet? Now we talked about the different kinds of diseases. We talked about how to manipulate the different kind of things. And this is what we really need to treat in order to also address the comorbidities. But I think there's some things that is still needed. If you see here, this was a paper that we wrote together, Jacob and I, together also with the European Task Force on Atopic Dermatitis, where we really wanted to look at what is it that we're treating, the treatable traits. And this is where we really come together with the new treatments and the comorbidities. Because in all of the studies, what we see is that we see all of the objective measurements. We see EC score, eczema activity and severity index. We see the scorer. We see the POEM, we see itch and skin pain. But what we do not talk about is asthma, rhinitis, conjunctivitis, food allergy, and all of these things that I introduced you for, which is actually something that is also a treatable trait, and which is something that we need to take into account when we use all of these treatments. Some of them are very good in treating all of this, but we do need comprehensive data on these kind of results. You can also see we have the psychological and occupational domain. Why don't we measure if the patients come back to work, if they have better work presenteeism, absenteeism distribution? Why don't we measure their anxiety and their depression? We don't do that in the clinical studies, but I think it's something that we need to measure, because all of these treatments that affect both the skin on how it looks, but also affect the itch and the sleep, will certainly have an impact on all of these domains when we look at them. So this is what we call treatable traits. Sometimes you'll also hear the phrase of treat to target. And that really means that we need to set up something that we want to treat and then continue until we have reached our goal that we set together with the patients. But these goals are to be set within all of these different kind of structures here. So this is something that I would really hope that those of you who are listening here today will take with you home and say, well, we can of course treat the eczema, the objective things that we can see, but there's a lot of more things that you need to treat. And you do have the opportunity now, and you actually also had them before, but with new treatments, if they are available for you, I do know that for some it might be a more difficult thing than for me. But do take this into account, that eczema is not only in the skin. This is really to see, because this is from Matthias Augustin, who works in Hamburg, not so far from where I am, in Germany. And he asked the patients on what was most important for them. And of course, itching came in as number one, to get better skin quickly. So the speed of onset of the drug is also very important, and to be healed for the skin defects. But also, look here, 81% wanted to regain control of the disease, and they wanted to have confidence in the therapy. So for the patients actually also to be able to control the disease, in the sense that they don't have to be afraid that tomorrow when I go to my job interview, or on Friday when I have a date with my new beautiful boyfriend or girlfriend, I don't have to be afraid that I will have eczema all over the body. This is something that they really, really value very much. And I think this is one of our most important jobs as dermatologists, is to give them this control of the disease. Of course, all of these up here are also very important, rated important, but we need to give our patients control of their everyday life. And with that, I would like to say thank you. Again, up here, you can see the picture of our hospital as it is today. What I didn't tell you just before is that we have not only one helipad, we actually have 2 helipads. So all in all, we are officially an airport also. Nobody knows that, but we are. And down here on the lower hand, you can see the port of Aarhus, at least some of it, where you have the old buildings and you have the cathedral, which is the longest cathedral in Scandinavia and also one of the oldest up here. So if you ever come by, please come and visit. And with that, thank you very much and thank you for listening to me.